Morning, everybody. So essentially, I just want to cover some very basic stuff because from the last discussion and last meeting we had, it was very clear that a lot of you are swimming in certain basic medical terms. So I know it's very difficult to orientate certain things, but we will try to give you a basic overview. And as they go by, this is probably going to be one of many little topics like this. I don't intend to take too long today, probably around 30-35 minutes, just to go through some of the basic orientation. This is packed at a basic year one, day one medical student level. And some of the things that you all highlighted that I wrote down in my last note was looking at the basic anatomy, the what is the orientation, and in terms of the urinary organs, which organ stays where, stays above the other, who are the neighbors to, things that was a bit confusing. We will also go through some TURBT because we will raise a question, how come TURBT don't have dimensions? I think somebody was asking that. And TCC, how come TCC at different sites are called different things? So this is the very basic references. If some of you know this, then yeah, just bear with me because not everybody knows lah. So as you can see, that the references of how we decide things is standard all across the world. So as a few important things, the front is basically we call it the ventral side, okay? While the dorsal side, right, we call it the back. The dorsal is the back side lah. Medial always means to the medial, and which is the midline that you can see down there. Okay, I'm trying to mark this right. Okay, can you see medial? Medial means in the midline. Huh? And sorry, medial is this one. Median is the whole line across like that. When we say anterior, it basically means in front. Okay, there's a few ones that are not there because it's very hard to go and find anything. Anterior means in front. Posterior means behind. And everything is relative. For example, whatever organ, the bladder, for example, is anterior to the is superior, is and in front of the uterus. So we call it that the bladder is anterior to the uterus. If it's behind, we must say the uterus is posterior to the bladder. That's where posterior anterior comes in. Depending on which references you are talking about, you can be in front or behind that organ, and hence anterior posterior comes in. Then there are something called superior, inferior and superior. This one only got inferior. Oh, there should be a superior here, got cut off already. Superior means on top. Inferior means bottom. Okay, so for example, the hands, the arms are on the superior aspect of the whole body, while the legs are in the inferior aspect of the entire body. Inferior means lower down, superior means higher up. Okay, so these are the common terms that you will likely see and encounter in some of the histology report that you will get. Okay, I think Fiona just joined us. Okay, good. Yes, that's fine. That's fine. So sometimes you hear distal and proximal. Okay. Distal and proximal means. Sorry, Fiona. I think for those of you who are not speaking, can you mute? Because I'm hearing a lot of feedback. Thank you. So, sometimes you hear distal and proximal. Distal and proximal is also another way of organizing certain things in the body. So, distal actually means far away. Proximal actually means closer. So, for example, if you look at anatomy of the kidney, this part is called, we use the body is the center that which we reference to. Anything closer to the body itself, the middle of the body, we call it proximal. So this is called the proximal ureter. This part is called the distal ureter, so it's away from the main body itself. Where does this relative terms comes in? The relative terms comes in is, for example, you have a lesion here. The lesion here, okay? So we will say that this lesion is in the distal ureter because it's far away from the body itself. Or you have a lesion that is here, a stone, for example. There are two stones. The first stone, this stone number one, you call it the proximal stone, which is closer to the center of the body here. That is further away, this second stone, you call it the distal stone. Same thing with lesion. Let's say you have two lesions. The proximal lesion is always this one because it's closer to the center of the body, while the distal lesion is the one that is further away from the center of the body. And that's how you actually orientate yourself. These orientations are very standard. They are used everywhere in the world. Okay, so nobody changes it. But it takes a while for you guys to remember because there are so many ways to describe the same thing. You can use the word proximal to this, distal to that. And to understand all this, you must basically understand the basic distal orientation that we are talking about.
Dr. J, can I ask?
Yes.
So
sure.
Distal and proximal, the reference point is always the middle of the body, is it?
Yes. If it's not well mentioned, it is always the middle of the body, the closer to you.
Okay.
The center of you, it is like that. It's never mentioned. Sometimes, if you want to, then if you have a reference point, which is, let's say, the stomach, okay? Distal to the stomach, that means far away from the stomach, or proximal to the stomach, closer to the stomach. Of course, if you have a reference point, then of course it's distal to this organ. It could be bladder, it could be prostate, it could be kidney, or proximal. So, but let's say there is no, they don't say a reference point. It is then reference to the center of the body as the norm. Does that answer your question, Elaine? Okay. Yes. Any other questions at this point? Anybody wants to ask now before we go on to more terms? Anybody got any questions? Feel free to speak up because I can't see the chat. Is there a chat? Oh, there's no chat. Okay, good. No questions, then I'll carry on. Basic anatomy. I understand that this is urology, and sometimes the medical doctors just basically blah 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 blah. People like me and Hong Hong is blah 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 blah. You have no idea what we're talking about. So it's very important for you to understand the basic anatomy of at least the urinary system. So I have here a simple basic anatomy. These are the organs that me and Hong Hong as urologists in the urology department are interested in. On top of it, we have the kidneys. Okay, these are kidney. And with everything on, as per everything on medical imaging, the orientation also matters. This case, this is the left kidney. This case, this is the right kidney. Okay, so let's go back to what we were saying just now. This part is superior to the kidney. Let's say we use the kidney as a reference, and then basically inferior to the kidney. Okay, so this one will be the left side, and this one will be the right side. This is how we orientate. In all medical pictures, you must understand the left is always on this side of the screen. while the right is always on this side of the screen. I know this is, if you're looking at it, the right, this side is actually your left hand side. But when we use right, we actually use reference to the patient itself. To this person, this is indeed the right hand. Or think about it like that. That's why sometimes you all don't understand. Hey, the left and right also a bit of funny. So remember, we are always relative to the patient. This is the patient's left. This is the patient's right. This is the superior aspect. SUP, inferior aspect. Okay, so let's say you use kidney as the reference point here. Okay, this is how we orientate. So the kidney is the first organ that we are always interested in, then followed by the ureter. This is the ureter itself. Ureter is basically the tube that connects the kidney to the bladder. The kidney makes urine. It is a very vascular organ. There's a lot of vessels that goes in and a lot of vessels that goes out. What it does is that the kidney filters out everything from the blood. It doesn't filter things from the food tract, which is the gastrointestinal tract. It actually filters all your metabolites, all your all the electrolytes from the blood itself. The blood goes through here up to 36 liters per 3,600 mils per minute. That's how much blood goes through. So many small little veins inside, glomerulus inside, and filters everything, takes out everything I want. Keep everything I want and throw off everything I don't want in the form of urine. For example, toxins like urea, like creatinine, is essentially things that the body kicks out onto and put it into the urine. So once the urine is made in the kidney, it goes down into the ureter to be stored in the bladder. The bladder itself stores all the urine. Okay, for a male, usually around 300 to 400 mils. For a female, usually 250 to 300 mils. Of course, there is a wide variety. And depending on how often you store and how much you drink, usually just as a question that you ask, I get a lot of questions. You go to toilet around 3 hours on a normal daily working routine. So for all of you here who only go toilet once a day, you're either not drinking enough water, or your bladder, you have trained yourself so well that your bladder capacity is way more than this level that we talked about. So this is female, this is male. Okay, so this is bladder. Ureter. Sometimes you will hear terms like proximal, mid, and distal. So remember I say relative to the center of the body. So proximal means close, proximity, close to the center of the body. Mid ureter is like in the middle, where the distal ureter is far away. How do we decide which part of it? By rough standards, there are many ways that anatomically anatomists, which is people who study anatomy, divide them. Some anatomists divide them according to bones. Some anatomy divide them according to functionally. But for the purpose of our discussion, usually we just chop them into 1/3. Okay, so if you are like, basically we say distal, proximal. Distal is basically the distal 1/3, the mid 1/3, and the proximal 1/3, depending on where is the lesion. How does this matter? It matters, let's say I have a tumor, which is some form of tumor that I will go through, and this tumor, it grows on the top of the ureter, the middle of the ureter, and distal of the ureter. It gives you an idea, is it closer to the kidney, or is it far away the kidney? Is it closer to the bladder, or is it actually closer to the kidney itself? Okay, so this gives you a context that you get an orientation. I thought it's really you have no idea, you have no concept of where things are. So this, in short, is the orientation of the basic anatomy of the upper urinary tract. Okay, upper urinary tract. How do you define upper? Anything that includes the kidney, the ureter, we consider the upper. Bladder and below all the way down to the urethra, we consider lower urinary tract. This is upper. The other one is lower. Okay. So that's in short the upper urinary tract that we talked about. There are various. So let's talk about a bit about the lower urinary tract. Lower urinary tract, because it's lower urinary tract is anything that is from the bladder all the way until the point where the urine comes out. So naturally, this is a male. Of course, the urethra is the main differences between the male and the female urinary organ. I don't have a female one, but essentially it's more or less the same. You see whether I can get you a female on later. But for now, because I wanted to talk about prostate cancer, so I use a female tract first. But the similarity is basically the bladder. Okay, the bladder itself is the bladder, and everybody has a ureter that comes in. Up to this point, everything is the same, whether you are male or female. The capacity is the one that's a bit different. This, my friend, is the prostate that you heard so much about. Okay, and anything distal to the prostate. Remember, I used the word. This is the prostate. Distal to the prostate means to say further away from the prostate. Distal to the prostate is the urethra. Essentially, this red line that I am drawing here. Male urethra, 10 to 15 cm. Female, 1 cm. We have two sphincters for male. Sphincters are basically doors. They are the doors of the urine. That prevents urine from coming out. This is one door. There's another one here. Ladies, I'm sorry, you have only one sphincter. So now here there's two things that I want to basically tell you what is the main difference. Because of the length of the urethra, that is why ladies are prone to having urinary tract infection. Why? Because outside the body is dirty. It's dirty. And if you can get bugs, E. coli or something like that, into the bladder or the urine tract, you get a urinary tract infection. You can imagine the guys have 15 cm before they reach this part where the urine sits. So it's not so easy for guys to have urinary tract infection. For ladies, it's only a 1 cm difference. Hence, it's a lot easier to get urinary tract infection. The urethra is here. This is female 1 cm. Here, the distance is really very small. Okay. Another difference, Another thing, guys have 2 sphincters. Girls have 1 sphincter. For the ladies outside, you've heard that sometimes ladies, when you have full bladder, you sneeze, when you cough, you have stress urinary incontinence. What's stress urinary incontinence? So basically, when you cough, right, the pressure here increase. Achoo! If you all don't believe, next time you actually go and sneeze or cough, you realize something, that your body is actually tense up. The stomach area is actually achoo. And sometimes, right, we achoo, basically the intra-abdominal pressure all increase, and it also increase downwards. So here you have a lot of organ, which is your bowel and everything. It basically push everything downward, including onto the bladder itself. If you have a very short, your bowels are here, you push everything down, you've only got one door and a small urethra, a short urethra, ladies bleed. Now you understand, So you hear how come ladies leak and boys don't leak when they cough? This is the reason. Unfortunately, boys got two doors, you got only one door, sorry. Yeah. And because of the length of the urethra, basically it also means that that we have another protection. So I was saying the first urethra is roughly around here. The second one is around here. Why do we say roughly? Because technically you cannot the body in intraoperative the pictures this is how the body looks like. Everything looks straight one. Or you cut already, you can imagine everything looks straight one. It's not like, oh, the bladder is nice golden color, the urethra is nice this color and that color. Everything is red. There is no signboard that says, hey, this is the urethra here. So we roughly estimate it to be around here and here. So for prostate cancer, herein lies the problems. I say guys got those things. Okay, male. Prostate cancer literally is the most common cancer that we deal with. We take out this one, we take out the whole prostate, and then we join everything up together. So essentially, this is the kidney, this is the bladder, this is the prostate, this is the urethra. We take this away and we join them up to the urethra itself. By doing so, we take away the two doors that I was talking about. So suddenly, we went from 2 doors to 0 doors. Okay, so in certain reports and certain contexts that you will see, you will hear that prostate cancer patients, we always in our op notes or in our follow-up notes, which is more for Nasrul and Elaine, is that we look at the continence rates. Why we look at the continence rate? Because the operation, as you can see, we take away 2 doors, right? We got no more door. Leakage, urinary leakage to a patient who has undergone surgery for prostate cancer is a very, very common thing. Up to 8 in 10 patients who undergone this surgery will have some form of urine leakage. Because we originally had 2 doors, suddenly we got no door. We went from becoming better than the girls to suddenly worse than the girls. Okay? Now, for the ladies, you got no prostate. Ladies, no prostate. Okay? That's why ladies cannot have prostate cancer. Okay? In case you all don't realize. Ladies, no prostate. So that's why you don't have prostate cancer. Okay? Ladies have some other things that guys don't have. Guys have some other things that girls don't have. So we are all fair. Okay. So at this point in time, anatomy, anybody got any questions now? Questions? No? Hey, Elaine, you're recording, then I don't record. Stopped. Any questions? Any questions at this point in time before I even move forward? You all seen some histological reports. Histology, Histology. What does histology mean? After I chop up, say the kidney, I send to the pathologist. What does the pathologist? So pathology is the person, it's a kind of doctor, it's a medical doctor. It's a medical doctor that looks at the various organs underneath. What they then do is basically they tell you whether you cut up the thing is got cancer or not. So for example, if you have a kidney here and you got nice little cancer, that you chop everything up, you chop this wedge up, okay, it becomes, you fix this part up, like that. So that little piece of pizza is sent to the pathologist. The pathologist look at the pizza and tell you a few things. Cancer or not? Margins. What is margins? Margin is how far away this thing is to the border that you've chopped up. And it's very, very important. Margins clear means the whole cancer has been taken out. Margins for cancer that is very, very, very close. What are the implications? It means you might have a bit of leftover here in the kidney that you fixed up. Make sense, right? So margins clear, margins negative, same thing. Margins positive is never a good thing. Because if it's margins positive relative to the segment that was come out, it means that at the edge, there were some evidence of cancer there. It means a lot of things. It simply means that your risk is not over yet. If you are hoping that for the surgery, you can cut out all the dirty stuff and you think that that's the end of your treatment, unfortunately, that is not the case. It means that you may potentially have some cancer left behind, and so you need to go for other treatment. So what does other treatment? I bring another terms. Basically, you will hear things like adjuvant and neoadjuvant. It's another fancy word. Doctors like to come out with fancy words. So when you have a positive that's margin, you need to go for adjuvant therapy. Adjuvant means it just means adjunct. It's assisting. It's the same, the root word is adjunct. So adjuvant therapy means that after the chemo, even though the cancer has been taken out, you need to go for adjuvant therapy. That means not over yet, still have something to do. So what the hell does neoadjuvant mean? Neoadjuvant actually means before surgery itself. Okay, before surgery itself, what are some of the things that that you can do? Let me just give you this card. Here we go. So surgery is here. I chop. Surgery is here. This part of the treatment is called neoadjuvant. This part of the surgery is called adjuvant. And it's always relative to the act of the surgery itself. What are the certain things that we can do before you go for cancer treatment? You can give him chemotherapy or you can give for radiotherapy. And after that, what can you do after the same thing? Chemotherapy, radiotherapy. Then you ask me, hey, how come I throw chemo and radio at them? Why? Because sometimes the cancer is very, 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 very big outside already. You want to throw something at him so that by the surgery, it becomes smaller. Then I can cut here to give you a margin negative resection. Understand? Sometimes I cut up already. I told you this is the dotted line here. I might have a bit of residual tumor that it was very, very close. So I go for adjuvant therapy to target this area with either radiotherapy or take chemotherapy to try to heal this part as well. Okay, so this is the concept whereby sometimes you see some reports say, hey, post neoadjuvant chemotherapy, something cancer, or adjuvant S or NUTUC status post SP, status post adjuvant this and that. Hopefully that gives you a bit of context. SP is another term that people use. you see this term lah, something status post RALP. ILP means this word means status post. It means after. Don't ask me why. People like to come up with wonderful terms in medicine, but it basically means after. Okay, so it means you got prostate cancer. Status post means after surgery. This is the kind of surgery that he went to. Okay, sometimes RCC, status post lap nephrectomy, same thing. It means he had RCC after the surgery done, meaning to say this guy is already have the surgery done. That's what it means. Okay, it's another term. It's very hard to put it anywhere, but it's got to go somewhere lah. Okay, I'm gonna stop here. Anybody got any questions so far? We haven't gone through any specific cancer, and I purposely didn't do it lah. I only briefly touched on cancer here, but we haven't actually even gone for into prostate cancer here. For now, anybody got any questions before, or you're all confused already? No? Can I go on? Can? Questions? No? Yes? Nobody? Nobody means I carry on. Okay. So this is prostate cancer, and I thought it's only right that we dive into prostate cancer because prostate cancer is the most common kind of cancer that we have in our registry. The concept of cancer treatment, there are some principles of oncology. Is basically clear margins, adequate resection. It means many different things, but any concept, the main principle of any surgery or when dealing with cancer is, in layman terms, you want to take everything out, correct? To take everything out is the best way to make sure you got no cancer left. And of course, you take as much as you can. What do I mean? Sometimes, if I've got a cancer that invade everywhere, let's say in this case, the prostate cancer invade here already, wow, or invade into the bone already, to the anus. There's only, or invade here to this part. This is the bone here. If it's localized, I can still chop, but if it invades elsewhere, go to somewhere else, or too massive involvement on the side, you won't do anything, you can't do anything. So this is what we call unresectable cancer, because it invade until, don't tell me you invade one leg, a chop of leg, it doesn't make sense. And we do not cut everything as we can, because we want to maintain a quality of life to patients. We can't chop everything off. So we will not do all operations just to remove everything under the sky, and make sure that you whatever we do, we try to make sure you have a decent quality of life. So there are some cancers that we call it unresectable for that reason. Okay. Now, so for the cancer surgery itself, right, everything goes back to clear margins. We try to remove everything with a bit of margins. Margins is this part, so that there are no residual cancer inside. Because cancer itself is a very big surgery. What's the point of you going through all these things, right? And you not having a cure. So if it's, when we do surgery, we really want to make sure that everything comes out. When we mean everything comes out, the best way to everything comes out is to take it out in one piece, like I just draw. We don't take chop one piece, we don't take chop one piece, we don't take chop one piece. Why do we not do that? Because if you cut into the organ itself, there's a chance that microscopic spread can occur. We try to take out in one chunk like that. Okay, so that's why most cancers, I use the word most, cancers can give you dimension. 5 by 3 by 5 cm prostate. Clear margins. Most can give you a dimension. If you cut the kidney out, they will give you the kidney measurement 10 by 5 by 7 cm kidney. This is the measurement of the kidney with a lesion that is 5 by 5 by 5. So now you understand sometimes how come one specimen can have 2 dimensions. They tell you the whole organ dimension and also the dimension of the lesion itself. So for kidney, it's not surprising to have 2 dimensions. Dimension of the kidney and dimension of the lesion. Prostate cancer, same thing. Dimension of the prostate. And usually they will tell you areas of the lesion itself. But the prostate cancer, that's where the confusing thing comes. Prostate cancer sometimes, before you even do the surgery, sometimes do a scan called prostatectomy, MRI prostate. The MRI prostate basically puts your prostate through a scanning, and they measure this dimension on the scan paper. Dimension, usually they give you 3 dimensions: long, length, breadth, and axis. And depending on how the radiologist draws, sometimes he draws like that, sometimes he draws like that, sometimes there's no good orientation. And really it's about how you put the cursor from one to the other, right? That depending on who pulls the cursor, sometimes they measure 5.1, 5.5, 5.2. There are variabilities in the measurement. But as long as the general size is correct, it's okay. All right, so that's why you see that sometimes the MRI prostate, there's this left lobe cancer that says it's a 5.3 cm by 4 cm. But when you cut out the actual specimen, they tell you the lesion itself is this another reading. But generally, if it's in the same region with close enough measurements, we consider to be the same one that we're talking about. Why? Because different people use rulers. Even the rulers can have different measurement on the computer screen. The resolution itself, it can affect the measurement itself, which is why sometimes the measurements are a bit different. All right, so don't get too sussed up and don't get too frustrated if you don't see, how come I cannot find he says 5 here, then it turns out to be 4.5 in the actual sample. Is it the same sample? Don't bother too much about it. It's about the same. Okay, as long as you say margin is clear, because whatever we do, we try to take some margins around there. As long as margin is not involved, the measurement and dimension itself is not so key. Okay, now I jump to what are the situations that you don't have measurement, because this is one question that I think Inan asked in the last meeting. How come bladder cancer don't have? This is a picture of the bladder itself. This is how I put a camera into it, and I see this lesion growing here. It's quite nice, by the way. It looks like corals. This is this tumor itself. This is the tumor itself. It looks like, for those who will dive, it looks like corals. How do we then take up this kind of cancer? So I'm just going to give another schematic diagram. There are some cancers, obviously, if you can just look like that. How do you actually remove this cancer in one piece and give me dimension? So if this cancer is like that, we go in with our instrument, and if the instrument is big enough, we just give you one scoop, cut like that. It's like an ice cream cutter, okay, with the cut everything. Then you see the specimen. We can give dimension. Usually these are small. Remember, this is a very small instrument. This is not 1 cm. It's probably 5 mm maximum by, you can cut maybe a 5 by 5 mm maximum. So essentially, if it's less than, it's a 2 mm specimen by 3 mm long and thin one, we can give you dimension. Most of the time, however, the tumor is like that, with a little stalk at the bottom, grows into the roots here. Muscle layer, we call it the muscle. Okay, this is the bladder. It goes into it. My instrument, remember, is still so small. So you can imagine when I come and do the surgery, I chop one here, I chop some here, I chop one here, I chop one here, I chop until the end. It comes out in many pieces. So if anything else, you cannot reassemble the pieces, where they give you grams. 5 grams bladder cancer. I say to you, right? Why do I do that? Because I don't have trust the instrument is very small. But I also say, remember in the last picture that we went to, the principle, Jay, you just said that the principle is really about having a full resection, taking everything out in one block. But there are some cancers, you can imagine these kind of cancers, right? There is no way that I can remove it in one piece. Why? Because I go through the bladder via urethra. The urethra is only that small. It's around 5 to 7 mm wide. My instrument naturally has to be smaller than a 5 to 7 mm instrument. And essentially, I cannot cut out a 2 cm bladder cancer in one piece. We call it en bloc resection. That is why for bladder cancer, you always don't necessarily have dimension. Instead, you have grams. Okay? Some other cancers, apart from bladder cancers, are also like that. Bladder cancers, they are very unique. It's also one of the few cancers whereby the doctors, oncologists, will allow you to chop out bit by bit cases, because there's no really any other choice. Even if I do a very nice little chop here, I took out this whole, I cannot bring it out because the urethra is so small. So I also had to end up chop into small pieces to bring it out piecemeal. Okay, so while we strive, most cancer we strive to take out in one piece, certain cancers, there are certain exceptions like bladder cancer that we chop in many pieces. Okay, so that is reason why sometimes, most of the times you can get some dimensions, and the bladder wise, it's likely to get a gram more than anything else. We can go through the next session and the following session. We can go through in depth on the various types of cancers. But for now, today, if anything, we'll probably just focus on prostate cancer. Now, again, I'm going to stop here in terms of the dimensions. Anybody got any questions? And hopefully I've answered why you have a question, which is sometimes bladder cancer dimension is always missing. Questions, anybody? No? Feel free to ask, man. This is about the only chance you're going to ask, because there's nothing such as stupid question. Just feel free to ask, because I don't expect you all to understand the thing. So if you have any, just let me know, then we can answer accordingly. Okay.
Dr. J.
Now, yes.
Desmond here. So
Yeah.
just now you mentioned for the prostate cancer, you MRI the prostate, and then the radiologist will measure from the MRI image, right?
Yes.
But the actual sample might differ. So usually the actual sample will be bigger, right? Because of the margin.
Or smaller. Bigger or smaller? Okay,
Oh,
smaller
okay.
what? Because
Okay.
different ruler. One is electronic measure on the CT, on the computer screen, the MRI. Actual sample itself, they usually use metal ruler, or, kind of. It's a bit hard. And sometimes it's irregular shape. And if it's irregular shape, depending on how you put the ruler, you can be the across the breadth and the thickness are totally different thing altogether. You understand?
Okay, I see. Thanks.
Yeah. Oh, so there will be. But what we are looking for differently is actually to make sure that they don't have big differences. So as long as you have one cancer don't become 3 cancers. And then we are not too bad. And because we take prostate, certain cancers like kidney, you take one side of the kidney out, which is okay. But for prostate, right, you don't really matter whether it's on the left side of the prostate or the right side of the prostate, because when you take out the prostate out, right, there's a central middle lesion here, right? You take everything out. So as long as whatever is inside the prostate and the numbers of lesion do not matter. What matters is the outside border is clear. The margins are clear. It's very different, however, you're looking at organs like the left and right. There's a left and right. You cannot tell me, oh, you take the left side got kidney cancer, you take out the right side and there's no tumor found. If you ever see a no tumor found in the histopathology report, you can imagine there's a lot of backstory to it. One of the biggest problems that we have is occasionally we get no cancer seen in our specimen. Alright, so there could be multiple reasons. The big and the most obvious ones is can cut wrong side, which thankfully doesn't happen often. Other more common and more acceptable reasons are like, oh, you went through neoadjuvant treatment, shrink the cancer down, it was so successful, it killed all the cancer, and when you will resect it out, right, there was no viable malignancy or no viable cancer found. That's some of the variations you look at. These are the ones that are not so bad. You cut wrong side, that's it, long one. That one sure die one. You can imagine there's a lot of backstory to that. Okay? Okay, so up to now, we probably covered 1 hour. Is it too much? Or you all can do a bit more? Carry on. Stop. We can do many sessions of these kind of things. We don't have to pile everything together. If you're agreeable, I don't hear any objections, I will probably go through prostate cancer. Okay, prostate cancer, here we go. Can you still see my screen?
Yes.
Yep.
Yes. Can I? Okay, can. Staging. I will use prostate cancer as a staging model. I won't necessarily go through staging itself. Okay. Every time you see in the histopathology report, there's this staging, and there's AJCC, and there's a TMM staging. These are basically trying to describe the same cancers in different methods, different ways, because their audience are different. So the audience, for example, is if you are talking to an oncologist, they prefer one kind of staging. While if you're talking to the pathologist who looks at the microscope and the cellular layer, they prefer another kind. So there are different ways. Hong Kong has this amazing big textbook, the AJCC guide. That's kind of like the Bible to all the various kind of staging. You can imagine there's a TMM staging. T stands for tumor, N stands for nodes, lymph nodes, and M stands for metastasis. So for example, in this picture, you can see they all have T. You see T staging, right? T tells you about the tumor size. The smaller the number, the smaller the cancer. Okay, and this is the same for all cancers that you will see. If you don't believe me, we can go to kidney cancer. Let's just look at the stage. Again, kidney cancers, T0, T1 small, T2 bigger, T3, bigger, or involvement more in T4. And there's no T5. It's usually 1, 0 to 4 maximum T. There's no T10. So it's T0 to 4. Okay. Now, then there's this lymph nodes. If you see this one, I cannot, don't know whether I can draw here now. You can see here, there's regional lymph nodes here. That's the end staging. Why does it matter? Because lymph nodes is usually the first site of spreading. On the scan, we can tell many things. We do a scan of somebody with kidney cancer. We do the T staging. It tells me I can measure. And let's say if this guy is less than 4 cm, it's a T1A. Then the next thing I look at is, are there any other spread? Other spread, obviously, is I already said the cancer is 4 cm. There's no spread. There's no, it's not, invading into the left side or invading into the right side. If it's invading into the renal nearby structures, regardless of size, it jumps to a T3A. T3A here, okay? Because size only matters if they are confined. But if there's small size, but unfortunately your nearby neighbor also kena, right? It is a totally upstaging of a cancer. That's why sometimes you see in the movie, initially thought to be stage 1 cancer, it jumped to stage 4. Because they found that actually there was a small part of it in the neighbor that got expected. Oh, if it's a neighbor only, no big deal. Why does the neighbor matter? The neighbor matter now because of the lymph nodes. What's the lymph nodes? Lymph nodes is basically our white cell line protection system. Lymph nodes is the one that basically has all the defenses in the bodies, the T cell, the NK cell, the B cells, and whatnot. They are the first site of deposits of a metastasis. So if let's say it spreads, usually the first place to spread are the lymph nodes. And if you do not have lymph node spread, or if you cut out a specimen, for example, the prostate, you go and take the lymph nodes around it. And if the lymph nodes are 0, you are fairly sure that the cancer has not gone beyond outside the organ. So it's kind of like another way we look at things. If you see an N1, it means that there were small little things, cancer cell in the regional lymph nodes. So we consider that as N1. What does it mean? It just means that the prognosis is worse, right? There are some cancers that even have M2. Because why M2 and M1 difference is first level drainage, second level drainage. So in a way, lymph nodes probably can be best explained by the neighboring doctors that you see. The first point of care, if any of us is sick, we go down to the doctors nearby, which is the first point of care. If the first point of care, then doctors say, oh, your condition is very serious, very, very serious. You must go to the second level of care, which is usually the hospital. You go to the nearest hospital, which is a regional hospital, say like Yishun, like Woodlands, like Ng Teng Fong, and you see the cancer, that is condition that you have. Oh, it's very, 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 very serious. Surgery cannot do. Must do radiation and therapy. Then it's sent to the super big hospital, which is like NUH, SUH, and TTSH. So it's layering. Same thing. Lymph node, first level of drainage is the closest level of drainage. If that level of drainage sometimes you can actually take off the first level of drainage, and then hope that the second level of drainage don't have, and so on and so forth. That's why there are some M1s and M2s, okay, depending on how. And in certain cancers, if you have M1 lymph nodes regional, you take out the lymph nodes fully, it's still considered a cure. However, in most cases, if the lymph nodes are fairly involved, then in that case, it's you may not take everything up. So even if you take 10, the 11th one is still inside the body. It's still considered as not a curative resection, because that lymph node, you still have some deposit there. And if it spread to the lymph node, it's so small, usually you can't tell. It's never a good thing if you spread to lymph nodes. When you leave the cancer in the body for too long, lymph nodes are already involved. And worse than that, another organ is involved. Then we call them M1, metastatic, distant metastasis, M1 disease. M1 disease, M1 disease means that it's not just lymph node spread. It's already gone to spread to the neighboring organ. It's not a good thing. So again, M1 and N and M are only got 1, 0, and 1. They don't have 1, 2, 3, 4, unlike most of the sizing that you see in the primary tumor here. They only have 0, 1. Some cancers have N2. And any cancers that have M2, not much. I think most of them, for the majority of discussion, majority of them has only M1 disease. Nobody talks about M2 because means spread already. Never a good thing. Okay, so that's what TMN is about. All right, TMN. There are so many T's, so many ways of arranging N's, and so many ways of M. Each cancer is different. Okay, the staging size for each cancer is different. The way you count T1 in breast cancer is different from the way you count a T1 in a kidney cancer, in a bone cancer, in a stomach cancer, in a pancreas cancer, in a lung cancer, everything. Which is why each cancer has its own TMN stage, which is why that big book is very big, because every single little possible organ, everybody wants to come with their own cancers and their TMN staging. There's no one size fits all. If you were to tell the patient, or we use the patient, hey, auntie, you got T2A, M1, N1, T2A, M0, not with 0, cancer. Auntie looks at you, and the patient looks at you and says, huh? What do you actually mean? That's why it's not very useful. Hence, we come up with something called anatomical staging. We group certain combinations of numbers together into various stages. And these are the ones that patients generally pick up. Why? Because they see TV. TV every day say, oh, the lead actor has a stage 2 cancer or stage 4 cancer. Again, it's 1, 2, 3, 4. There's no stage 5 cancer. Stage 5 means you die already. So we then group according to anatomical and prognostic stages, whether you have T1, which is the lowest one, I don't have a pointer, sorry, T1 or T2, which is slightly bigger than the T1, and let's say you have a bigger one plus a bit of lymph node involvement here, that's stage 3. If you got stage 4, it's a very, very big tumor, or there's a lymph node involvement, or there's an M involvement here, stage 4. So in the movies, you see people cry stage 4 cancer. That's the reason why. Because it's stage 4, no more. I can explain to you, they are used by different people for different reasons. Most people that you talked about will never understand or know much about the T, the M, and the M staging. Most people, however, will know the stage 1, 2, 3, and 4. And this kind of the way you arrange stage 1, stage 2, again, is different for each cancer. So that's why sometimes you see, you read somewhere, stage 3 cancer, stage 2 cancer, stage 2 renal cancer for staging. Or you can see a T2 M0 cancer for surveillance. They mean the same thing. You're not expected to remember all these things. Depending on what the cancer is, everybody goes to that big book and find out staging and then to find out. So you're not expected to remember everything. So that's the good thing. Okay. That is in the long and short. This is what all about. This is American AJCC stands for American Journal of Cancer Classification. American Journal. So the journal. So basically, there's a lot of old wise men that sits around a joint committee of cancer staging. All wise men that comes around in their respective specialty, and every year or every 2 years come out and decide that, hey, are we happy? Did we learn something new about the cancer? Do we want to change certain things? Do we not want to change certain things? And if they change certain things, for kidney cancer, for example, there are versions. 2014 version is different from 2010 version, which is again different from 2018 version. Why? Because in the last 4 years, they learned something new. As technology go by, they learned something new. And they could also better classify it. One thing I forgot to mention, that what's all this staging? Staging is useful because to the clinician, it helps guide prognosis. Prognosis is another word. Tells you how likely you're willing to get well. For any cancer, stage 1 cancer, the prognosis is good. For stage 4 cancer, the prognosis is bad. So if you have why does it matter to me? Because stage 4 cancer, sometimes we don't operate. Why? Because the operation itself causes more harm. So no point. Let you rest. I mean, go and do whatever you want to do. While stage 1 cancer, almost invariably everywhere in the world, most stage 1 cancer get treated one way or the other. So AJCC, those wise men sit down there and changes the staging and changes the classification because it does help guide treatment. That's the reason why we care about all this staging, why it matters to registries when people like that. So this graph states that how individual components of the TMM staging at Gleason score, at PSA, gives you this, depending on the different combination. TMM is more of a physical thing. Some cancers, like the prostate cancer, has a Gleason score and the PSA, and they found that the PSA, depending on whether less than 10 or more than or less than 20, meaning from 10 to 19, makes a difference. If you are lower the PSA, you have a better outcome, hence you stay in stage 1. On the other hand, if you have a very, very high PSA, even if you have a very low staging, you are stage 2B for that matter, because everything guides treatment. All right, so this is again an entry into TMM and AJCC classification. And again, this is only specific, this diagram is only specific to prostate cancer. And we group the stage together. Okay? Any questions so far? Right? So I think today we probably will stop here. All right? Any burning questions for today's skim through? We will need to go through the cancers one by one, maybe 2 by 2 the following time, but this is just to give you some idea of the various terms that you see. I hope that it's actually helpful to you all, and that basically it gives you a bit of a idea of what we do as a clinician. It helps us. It helps us in many ways, because we use the staging to tell uncle, very good, stage 1 cancer, don't worry, take off everything, will be good. And then the other ones, we hold their hand and say, you know, not so good, things like that. But the downstream application to you guys is you all see a lot of these kind of terms in the reports that you all get, histological reports, radiology reports. Just give me a second, I'll show you the book. Show me the book. Here one is. Okay. This is the 葵花宝典, or the manual that we use, or rather registry people like me every day must read this kind of book. This is the, as you can see, the 8th edition. You can imagine every few years they come up many editions. So this page, for example, shows you the gallbladder cancer and the various staging involved in the gallbladder cancer. Anyhow, pick one, and you have very, very common cancer, which is breast cancer. Different ways of staging as well. People spend an entire career, people spend an entire rule and their entire life just to write these kinds of various rules for classification and whatnot. So a lot of effort, a lot of detail goes through this kind of thing. And this is how we actually spread our various data across in the recap database. Okay, so introduction to cancer. Any questions? Fiona, Inan, is it any burning question from your side? Because these people can walk up to us and see us and ask questions. Prof, soon anything that you are confused? Anybody want to clarify?
Just to clarify, the two terms,
Yes.
pathology report and histology reports, are they the same or they are not supposed to be the same?
Okay. The pathologists write a kind of report called, they are the same person, they're the same. Pathologists give you histology report. Histo, the word I think is some form of stain. You can see from the description of the pathology report, they tell you they are cancer cells or not, or just not by looking, because everything is red color. They actually put some colors that stains for acidic cell, fat cells, muscle cells, and they light up as different colors, pink color, blue color. So I show you. Let me show you. Share screen. Broadcast. So histologists likes to do. They write their histo reports by putting colors everywhere. This time you all can see, right? Can see? Can you see my screen?
Yes, can see.
Yeah. So they put different kind of cancers to put different kind of colors to catch different kinds of staining. And as a result, I'm trying to show you the nice pictures just now because it has a good, just going to, here we go. They people spend again their entire lifetime, probably easy to see here, to work on different stainings and different colors, H and E staining. And I think the root word comes from the H is the histological staining. I don't know what the H is, but that's why they're called, they use histochemistry. That's why they're called histology report, and it's written by the pathologist. The radiologist write down a radiological report, and the radiological report uses a CT MRI scan. That's more of a traditional history thing. So pathologists write histo report. And there are some other things like fluid. Sometimes we take fluid out and we go and stain. Okay, we go and stain it again, different things. And you hear this term cytology because it's mainly fluid based. Again, once you take a fluid from somewhere, you spin it out, take away all the things you rubbish you don't want, only left the cells, you put colors into it. They also come out as different colors. They are done by the same group of doctors called pathology. So if you see histological report, histopathology report, cytology report, they all come from a kind of doctor called pathologist. They are the one that look under the microscope into magnify. This is a magnified, widely magnified kind of thing. The radiology guy, radiologists are the kind that looks at the black and white scans like this. So they look, they go through all the scans that you can see, black and white. They spend hours and hours and hours in a dark room don't talk to patient one, don't want to talk to people one. They just look at screen. They come up with a diagnosis in a report called radiology report. That's the difference. Okay. Any other questions? That's a good question actually. So simple that people forget. I mean, it's very simple for us, but we end up not covering.